right. Welcome everyone to the weekly ArMA COVID-19 virtual town hall. We'd like to thank all of you for taking time out of your evening to join us for what's to be another very informative event. Tonight's webinar is brought to you in part by CompuGroup Medical US. CompuGroup, or CGM, is one of the leading e-health providers in the country, headquartered here in Phoenix, Arizona. CGM offers medical software and services such as telehealth, EHRs, practice management software, medical billing services, clearinghouse services, and laboratory information systems to meet the unique needs of physician practices, clinics, community health centers, medical laboratories, and schools. These solutions improve ROI, care coordination, and healthcare outcomes. For more information, you can visit them at cgmus.com. A little bit of Zoom housekeeping here for you. This is a professional environment, and we ask that everyone remain respectful towards all participants. This webinar is being recorded and will be published for others to view at a later date. We have typically been publishing them on our YouTube channel. You can see and hear us, all the panelists, but we cannot see or hear you. This webinar is best accessed from your computer. We best utilize at the bottom bar where you can submit questions through the Q&A function. Please do not submit questions through the comments. Try to utilize the Q&A function as much as possible. And the best viewing option is to fit the screen to your window. Tonight's moderators are myself, Damian Johnson, the Director of Communications here at ArMA, as well as Megan McCabe, ArMA's Deputy Director of Government Relations. And I'm happy to welcome our panelists tonight. We have Pam Kahali, President and CEO of Blue Cross Blue Shield of Arizona, Dr. Jim Napoli, Chief Medical Officer, Blue Cross Blue Shield of Arizona, Dr. Sarah Selleck, Chief Medical Officer for Access, Dr. Ross Goldberg, ArMA's current President, and Juliana Stanley, ArMA's Director of Practice Support. And at this time, I'm going to go ahead and turn it over to you, Dr. Goldberg, for a quick update from ArMA.
Thank you very much, Damian. Thank you again to our panelists, and thank you all for attending again tonight, our weekly town hall. We appreciate the participation. Very briefly, because obviously you're here to see our panelists, not me, I wanted to update everyone. As a healthcare community, we had to move very quickly to telemedicine platforms in the midst of COVID-19, and that understandably caused some confusion among everyone. So we're happy to have our senior leadership from Blue Cross Blue Shield of Arizona and Access join us tonight on this town hall to help clarify current regulations and maybe have some discussion about what the future will bring. In order to set the stage, this slide really provides highlights from what the executive orders have been coming from the governor regarding telemedicine. These orders are in effect for the duration of the public health emergency, which we don't know when that's ending yet, so that's why they're still in effect. So basically, during this time, all health insurance plans by the executive orders are regulated by the Department of Insurance. They must, in the 4 points there, reimburse practitioners at the same level of payment for telemedicine as they would for in-person services, provide coverage for all healthcare services that would be covered by an in-person visit, allow all electronic means of healthcare delivery, including telephone or video calls, and allow a patient's home to be an approved location to receive telemedicine. The governor also lists a variety of healthcare professionals that may use telemedicine, including physicians, physician assistants, advanced practice nurses, psychologists, occupational therapists, and others. Additionally, Access will mandate all Medicaid plans to allow the same coverage for Access members as are covered by commercial plans. That's all I really wanted to say because we have far greater experts on the phone, on the Zoom, I should say. With that background in mind, I'm going to transition over to our first panelist, Dr. Sarah Selleck, the CMO of Access.
Great, thank you so much. Appreciate your time this evening. And so I'm going to be providing an update on the Arizona Medicaid's approach to telehealth, as well as our response to the COVID-19 emergency. Next slide, please. And so my talk today will overview the changes we actually made back in October of 2019, the changes that we've made since the emergency was declared on March 11th, and then save time for questions as well. Next slide, please. And so going into the October 1st, 2019 changes. Next slide. We have greatly expanded our approach to telehealth starting back in October. And so we were quickly able to pivot when the emergency hit in regards to the expansion of a policy that we've already implemented. And so for many years now, there has been this push, understandably so, for additional telehealth services and coverage through Medicaid. And so back in October, we broadened our place of service allowable for both distant and originating sites. And we specifically specified that for where the member is located or the patient is located, that we would cover services delivered for place of service home. And so that was a great expansion. And we felt that would greatly expand access to care, would also have some cost savings from the standpoint of Medicaid does cover non-emergency medical transportation in Arizona, and so there was some offsetting costs there. We also clarified that we have no restrictions on the distant site, which is where the physician or the provider is located. Additionally, we significantly broadened coverage for telemedicine, otherwise known as interactive audio-video communications. Previously, we had listed 17 specific disciplines that we would cover telemedicine for. We removed that restriction, and basically wherever it's within scope of practice, we cover it as far as telemedicine. Remote patient monitoring, prior to October 1st, we limited it to congestive heart failure based on the evidence. But starting on October 1st, we broadened it to whenever it's medically necessary and cost effective. And lastly, for asynchronous store and forward technologies, we greatly expanded coverage to specifically articulated disciplines in our policy. Next slide. We clarified that there are no rural versus urban restrictions on coverage for telehealth services. And prior to the COVID emergency, we did allow our managed care organizations, since Arizona Medicaid is primarily managed through managed care organizations, they have the ability to decide how they leverage telehealth within their network as long as there's adequate network coverage. But I did want to note that that has since changed during this emergency, and I'll go into that in just a minute. Next slide. We determined that we wanted to be able to track and trend telehealth utilization. And so we did adopt the GT modifier for real-time interactive audio-video communications. We also wanted to track where the service was being delivered for the originating site, which is where the patient is located. And so we've given those specific instructions for the billing on the claim. For asynchronous, we're using the GQ modifier as well as place of service for asynchronous services. And then we have, prior to the emergency, we had specific telephonic codes that were already open for telephonic service delivery. And at that, prior to the emergency, we utilized place of service 02, which is telehealth, to denote those services. Next slide. All right, so what have we done? What has Arizona Medicaid done since the emergency? Next slide. We did create a temporary telephonic code set. And so there was significant concerns raised by the physician community about having the ability to quickly shift to a telemedicine platform. And so based on that concern as well, coupled with the concern that not all of our members have broadband access, we greatly expanded the codes that we would reimburse via audio only, otherwise known as telephonic. And so I have listed here if basically our medical coding managers contact information, and that is who triages all the questions and requests associated with additional codes being added to our temporary telephonic code set. Next slide. And so on this slide is an actual link to that code set, which is pretty expansive and includes, for example, evaluation and management codes. And we have listed specific coding guidelines for your coders, your medical coders or billers in regards to how to denote those temporary telephonic services. And the effective dates are effective March 17th until the end of the COVID declared emergency. And so that's still to be decided. Next slide. We continue to maintain codes that were already open for telephonic use prior to the emergency and plan to maintain this code set even when the emergency is over. Next slide. And then during this emergency, we've also expanded our telehealth code set, which is telehealth we define as either that interactive audio video or asynchronous technologies. And so specific to telemedicine, we've added 161 new codes with the GP modifier since the declared emergency. Next slide. This is basically just a table describing the different technologies and the specific modifier when applicable, place of service, provides a specific link to the code set, and for all of our code sets, with the exception of the temporary telephonic, that they'll remain in effect post-emergency. Next slide. And then I wanted to bring your attention to our frequently asked questions on our Access webpage. So we have a specific section on our COVID FAQs just on telehealth and telephonic. So the first question is, can all Access covered services be delivered via telehealth, including telephonic and reimbursed by Access? And our response is that all services that are clinically able to be furnished via telehealth will be covered by Access throughout the course of the emergency. And we defer to the treating provider to determine, what's within the standard of care, within their scope of practice. And the way that we operationalize that through our billing and coding is by adding the specific CPT or HCPCS codes. And so the way that we've been able to operationalize it is basically based on community ask, in addition to our technical experts researching the codes that are available. Next slide. And then another question is, will all Access health plans and fee-for-service programs honor the use of telehealth or telephonic service and service codes as expanded by Access in response to COVID? And yes, regardless of whether a provider is specifically contracted to provide telehealth or telephonic services, Access health plans as well as our fee-for-service programs will reimburse for services. So this is basically stating you don't have to be contracted for telehealth to provide it during the emergency, that our health plans are required to reimburse, as is our fee-for-service program. Next slide. And then our Access health plans are required to reimburse at the same rate for services provided in person versus those provided via telehealth or telephonically. And yes, effective March 18th until the end of the emergency, we specifically provided guidance that our health plans cannot discount rates for services provided via telehealth or telephonically as compared to in-person. Next slide. And then here are the specific resources, including our specific Access Medical Policy Manual 310I, medical coding resources, as well as other resources. And so happy to take questions at right now or at the end.
Thank you, Dr. Selleck. I think at this point, since we don't have any questions in the queue right now, we'll just go ahead and jump right into Blue Cross Blue Shield's presentation. Pam, would you like to go ahead and get us started?
Great. Hello, everyone. Thank you so much, Damien. I'm so happy to be here. I have a couple of thank yous. First of all, thank you to all of you for what you do. It's particularly in this difficult time, it's just highlighted how important your work is in our community and for all Arizonans. So we are very grateful for that. Also want to thank Libby for inviting us. Libby is doing a great job representing you. She, whenever we go a little wayward, she just gives me a call and tells me what we're doing that we shouldn't be doing or what we need to be doing. And so the relationship is really great. And it's great to have somebody that's really transparent and open it helps us be a better company. And then I want to congratulate Dr. Goldberg for his new role. We're very excited to be working with you in your new capacity, Dr. Goldberg, and congratulations. It's a really great honor, and what a great position. I know that you'll do wonderful work for the community in this capacity. So I am going to talk about telehealth, which is probably the hottest topic now. There's webinars on telehealth pretty much every day, and it's been pretty extraordinary how quickly things have changed in this space. I was talking to somebody about a week ago, and they were, it's a large medical group, and they were telling me that they made, they had a strategic plan that they put together in January of this year. And basically it was that they were going to have telehealth up and running for the entire practice in 2 years. So they were phasing it in over a 2-year period. Then COVID-19 hit, and they brought it up in 2 weeks. And that's pretty much what you all did. And if you were to do a chart that mapped out the adoption rate of telehealth, it is a hockey stick. It's quite extraordinary. And one of the positive things that have come out of COVID-19 is this acceleration of this really wonderful tool that I know our members appreciate. So today we're going to talk about a couple things. First, I'm going to just share with you how we're thinking strategically about telehealth, how we started thinking, how we're thinking now, and how we will be thinking. Then I'm going to share with you a survey, some data from a survey that we recently did. You may have filled out the survey. We sent it to providers and to members, and it's about telehealth and their perceptions and how they're interacting with that. And then lastly, Jim is going to talk about some specific benefit and coverage information relative to telehealth. So Damien, if we could go to the first slide. I want to kind of rewind many years ago and share with you how we first were thinking about telehealth and why we did what we did. And this is where Libby called me and set me straight about a month ago. But when we first embarked on this journey with telehealth, and again, it was probably close to it. It was many years ago. We really had 3 objectives in mind. We wanted to provide our members with after-hours access to medical care. We wanted it easy. We all know that medical care and everything that is wrapped around it, like insurance, is really complicated. And our members are just screaming for simplicity, get rid of the complexity. So we wanted something that was really easy, convenient for them. And then lastly, we were looking for a lower cost way to give people access to care. And so we, as a solution, because the Arizona physician community did not have a standard for telehealth, we contracted with a vendor. And that was deployed, and that was going fine for many years. And then if you go to the next slide, COVID-19 hit. And we shift, the next slide, the pros and cons of our strategy. It really did meet all of the needs, convenience, cost, alternatives to accessing care on nights and weekends. But the one con that, and it's a big one, is that there really was very little continuity of care. And you had an individual that had a great relationship with their local doctor, and then they go off and do this telehealth thing, and then it's separated from what's going on with their doctor. So that's a big mess. That's a big downside to having a vendor solution for telehealth. So now to the next slide. COVID-19 hits, and the strategy for telehealth completely changes. We needed telehealth that would allow people to access care when they're sheltering in place. They're not leaving their homes. We needed it to protect what we were afraid of regarding a surge in visits to the emergency room because of COVID-19. We wanted to keep people out of the hospital, so we had the capacity to deal with that surge that everybody thought was coming, that we luckily have been able to mitigate and haven't seen that capacity issue achieve, but we were worried about that. And then lastly, we had elective surgeries that were delayed by executive order. And then we had people with chronic conditions that were at home and afraid to go out. And we wanted to make sure that those people had access to care during this very difficult time, because things could get really, really much worse if you've got these chronic conditions, or you're waiting to have a surgery done. You need to stay connected with the medical system during that time. And so here's where the Arizona community, all of you, quickly adopted telehealth and enabled this wonderful new world of accessing medical care through people's homes. So this is when Libby called and said, Pam, get it together. Why are you promoting a vendor? And so we quickly de-emphasized our vendor relationship, and we went out with communications encouraging our members to utilize their local doctor for telehealth services. And that was received very positively. Now we're going to the next slide. We've got to start thinking about what next for telehealth. And I call this post-COVID, but it's a very inappropriate name because it's not post-COVID, obviously, but let's call it the next phase. How are we thinking about telehealth? We are now, we've opened up elective surgeries again. Doctors' offices are open, more people are going out. Regrettably, they're not taking the appropriate precautions, as I see in restaurants and bars and grocery stores. Not that I'm at bars, but I've seen on TV that they're like packed now, and people are not wearing masks and they're not practicing physical distancing. So I'm a little bit concerned about that. But we still are we're in a situation where people can start doing things a little bit more what they would perceive as the old ways. So we expect more to be coming into the office now. So no, we still need to have a telehealth solution, and people are now used to it and they like it. So what we're looking for now in terms of our telehealth strategy is something that allows for continuity of care. It's simple and easy to access. It is lower cost option, and it provides after hours, weekends and evenings access to care. We would love for that to be the Arizona health system, all of you, and love to just not have a vendor. And so this is what we need to grapple with over the next couple months. How does this evolve and what does this look like? Now, as we think about that strategy, we thought it would be very helpful to get input from you as well as from our members. And so we did a survey, and this was actually really well responded to because people are very interested in this topic. 700 physicians responded to this survey, and almost 1,500 members responded, or excuse me, 5,000 members responded to this survey. So it's a very robust, accurate sampling of what the general thoughts are around telehealth. So if you go to the next slide, this is a slide that we asked questions of Arizona physicians, what's going on with telehealth. 91% of you are using telehealth platforms now. So that's, again, an incredible feat when you look at the time frame that you all adapted to this new world. It's really very, very impressive. The most common platform is Zoom, followed by FaceTime. So we're taking advantage of existing technology to deliver medical care, and so that's a great thing. The next slide speaks to the members' experience with telehealth this year. And we've got almost 50% of our members have used telehealth this year. 50%, and that compares to last year when the utilization was in the low single digits. So clearly we had a 3,200% increase in telehealth visits this year compared to the same time last year. It's extraordinary. And people like it. 72% of our members were satisfied with the telemedicine experience, and most of them used your platforms. Most of them used you as local doctors. The primary reason that the handful of people didn't like it was they had some technical difficulties, which we all, dealing with Zoom and FaceTime, we know the system is overtaxed. And there was some people that expressed this loss about not having the ability to interact face-to-face with the doctor. The reasons they loved it was convenience and ease of use. They love that. So here's the next slide, talks about where we've got a disconnect that we have to figure out. When we asked doctors, the 700 physicians that responded, what do you think we should pay? What do you think is a fair reimbursement for telehealth? The most common answer, 83%, said you should pay telehealth the exact same as you pay an in-office visit. We asked that exact same question to our members, and that's on the next slide, and those 5,000 had the complete flip response. 79% of members think that they should pay less for telemedicine, and there's 1% that feels that they should pay more, but the vast majority feel that they should pay less. And if you go to the next slide, there were a whole lot of comments. I pulled some comments relative to how they're thinking about it. I'll leave this up for a few minutes so you can read through some of those, but kind of in a nutshell, they will continue to use telehealth if it's convenient and easy and cheaper. And the reason they feel like it should be cheaper is, in their mind, there's less overhead. And that may or may not be true. I mean, you still have to probably have an office, and you still have to have a lot of the stuff that you have now where you see people, but there is that perception. And so we'll have to, in terms of our strategy, work with you all and figure out how we move forward with telemedicine in the future. So with that, I'm going to turn it over to Dr. Napoli, who is our Chief Medical Officer, and he's going to share with you some information on benefits and coverage related to telehealth.
Thank you, Pam. And thank you, Libby, Dr. Goldberg, for having us here. I always enjoy coming and talking at ArMA meetings. I just want to really echo the sentiments that Pam had put out about our frontline healthcare workers. The importance of what everybody does every day does not go unnoticed by us. And so thank you for everything that you're doing during this pandemic. Our goal is really to ensure that our members get the right care, uninterrupted care. We've seen an exponential jump in virtual visits, as Pam mentioned, 32 times the number in April compared to the same time last year. I think it's safe to say that virtual care is here to stay. One of the more encouraging things that I have seen is really an improvement in the quality of the virtual visits that we're getting. Before, we would see a telehealth visit almost always result in the prescription of an antibiotic being given. Over 90% of what we had seen before resulted in antibiotics, and those numbers have dramatically dropped. And I think the reason's pretty clear. Now the primary care doctors are involved in the care. They're handling more than just urgent care-like issues. So whereas telehealth before was for earaches and upper respiratory infections, it's really changed dramatically. And I think that's important for virtual care moving forward, because now it's really serving the purpose that it should be serving. It's just not, access of care is hugely important, but it's just not all about access to care. It's about getting that experience with the members that would emulate or be similar to what they would get in an office for the chronic condition management, the medication reconciliation, and all those things which are so important in the continuity of care, as Pam had mentioned. So kudos to our community docs for stepping up and being able to care for our members. We are seeing a difference, I believe, in the quality based on what we've seen so far. So the top categories that we're seeing primary care doctors see the patients for now, anxiety is number one in behavioral health, which, with social distancing or physical distancing, there's social isolation, and there is quite a significant uptick in behavioral health services that are now being accessed through telemedicine. Respiratory, cough types of issues are still up there, diabetes and endocrine types of diseases, hypertension. So we're getting a much different mix now in the types of things that we're seeing. So this slide here just is talking about what are we covering during what do we cover? And this is current to the COVID-19 coverage. So Pam asked me to really try to compose something and make it as simple as possible. So I did the best that I could, not just for this meeting, but just in general, because there's so many different things that are going on with the virtual check-ins and the e-visits and CMS guidance and the governor's executive orders. And I know Dr. Goldberg talked about some of those earlier on, but I really wanted to just try to make this and categorize these. And these basically are bucketed by the types of codes that will be used with them. And Dr. Selleck did a really good job, I think, of going over the codes that are used. So this is really a reflection of that. So as you see the telemedicine visits, which is in the first bucket up there, these are typically your two-way audio visual visits. Normally these would be synchronous visits. They're generally billed with a procedure code and a modifier. So we would see something like an office visit with one of the telemedicine modifiers. And the medical necessity documentation here is what we would typically expect to see in an office visit. So that would include the scope of practice that was mentioned. These have been expanded during the COVID situation to include the providers that you had heard about before, so very similar to access, the therapist, all in terms of provider types, there's been a big expansion of that. And also, if you'll see here, that based on the governor's executive order that was put out, is that if audio visits are meeting these requirements that a typical procedure code would meet, that they are also able to be billed as such with a modifier. So this would include things with medical decision-making complexity, presenting problem severity, detailed history, and all those typical coding things that would be expected in an office type of visit. As you look at the virtual check-ins over on the right top-hand corner there, these are also telecommunications, and this was really modeled after what CMS had put out. And so there are specific codes here that are different than the procedure codes with the GT modifiers. And this is really for an established patient. These are patient-initiated visits. They don't relate to a medical visit within 7 days or the next 24 hours. So these are handled differently than what we're seeing based on the governor's executive order that had been spoken about earlier. Also e-visits. So for patient-initiated communications with an established patient, again, CMS guidance here on the different types of coding. So this could be an online patient portal type of communication. And then finally, teledentistry. So these are consultations for problem-focused types of evaluations for dentists. Next slide, please. So just to talk about cost share waivers and what's going on. So Blue Cross Blue Shield of Arizona has recognized that there is a lot that is going on and affecting our provider community during this time. So we have put into place cost share waivers that are in effect during the pandemic to help alleviate some of these issues, including collection of payments from members and really kind of helping out with practice reimbursements. And so the members' cost share, as you well know, could be things like the copay, the co-insurance, combinations of these types of things. So we really wanted to show what we're doing in this area during the COVID pandemic. And so for our fully insured plans and our Medicare Advantage plans, we are now covering the cost shares on all the diagnosis codes. For our federal employee programs, we follow the guidance of the FEP program, and so cost shares are being waived for COVID-19 codes. Our self-funded groups determine their coverage and cost share. We really encourage them to follow what we're doing for our fully insured business and have ongoing conversations with them about the importance for the consistency that we like to see throughout our different lines of business. However, they are self-insured, and so they make their own determinations. Fortunately, most have been coming along with the guidance that we have put forward with our fully insured plans. And then the blue card plans are determined by the home plans. But we've seen a lot of collaboration throughout the Blues plans throughout the United States, taking very similar steps to help practices and members navigate and deal with the situation that the COVID-19 virus has brought upon us. So we continue to watch closely what is happening with the COVID situation. We continue to make updates on any guidance and put out frequent communications that we're doing through community or provider updates. We continue to have webinars weekly with our providers. We do have training, different things with billing and coding that you can find on our provider landing page with this Tele Everything, as I call it, guidance. And of course, we have our provider reps that are available for all of our groups for any types of questions. We do understand that this is can get a bit complicated, and we just want to be sure that we have those resources available to help from that billing and coding perspective. We really are looking forward to the potential that virtual care offers. It is going to be a very interesting development moving forward on how these virtual visits are coupled with other technologies, how they fit into clinical workflows in doctors' offices, different types of potential that they are offering. One of my friends who is a primary care doctor told me that he is going to use the virtual visits and put them in between the office visits when patients come in as he's opening up his office, so that he can keep his room, where the waiting room, less crowded, and he can kind of just work his workflow in a way that will help both people who want to come in and be seen, as well as those who want it to be seen virtually, which certainly there's going to be a lot of that moving forward. So thank you for allowing us to speak. And I think that is the end of our deck.
Great. Thank you both, as well as Dr. Selleck, for a great presentation here. Right now, we're going to jump into some questions for the panelists. Again, I just want to remind all the participants, if you do have any questions, to please do submit them through the Q&A button at the bottom of your screen. And we'll go ahead and get started with a question that was submitted prior to the beginning of tonight's event. How long will Blue Cross Blue Shield continue to cover telemedicine via synchronized audio and video visits, and to what extent? They also provided, for instance, audio plus video only, audio only, and then while Medicare will continue to cover telemedicine visits, will Blue Cross Blue Shield cover payment as a secondary payer?
Jim, I'll let you take that one.
Sure. The guidance that I had put out shows you what is currently happening today in terms of the executive order that the governor has put out, as well as other guidance. So as you had said, Dr. Goldberg, the governor's order is in effect until the state of emergency for Arizona has been lifted, which right now is to be determined. So we will cover the audio, moving forward, the audio video telemedicine services. We had covered them previously, utilizing synchronous AV visits with procedure code, as well as the modifiers. So that will continue. Currently, we will are continuing that up until again until the governor's executive order has expired for our fully insured business. As we look at the other lines of business, the FEP will be covered and was covered from March 6th throughout the national emergency. And then the MA is going to be covered throughout 2020. So there will be coverage, and depending on the line of business will depend on how long that is in play for, as it is today, versus how that will be covered tomorrow. The major difference, I think, that I will point out is that the telephone calls are currently covered under those telemedicine visits that have the procedure code and then the telehealth modifier. That will expire when the governor's order expires.
Great. Thank you so much to all the panelists. Next question is one that is asked live. The question is, it's interesting to see the expectation by BCBS members that telemedicine visits would be less expensive. Traditionally, those same members have expected physicians to handle phone questions, prescriptions, lab results, etc., without any charge because insurance is not traditionally paid for those types of services. How do the panelists see this issue moving forward?
So I'll start, Dr. Nackley, and then you can jump in. I knew that this would be something that might generate some discussion because it's such obviously a contradiction. I think what partly is driving the perception is the reality that has existed over the past 7-8 years, and that is that the telemedicine vendor charges less than the current on the boots on the ground. So we have a negotiated rate with the telemedicine vendor that is cheaper, and that therefore members' coinsurance is cheaper when they use that vendor. Employers that buy the benefit, they see that it's cheaper to have their employees go to this telemedicine vendor, and so they encourage that with communications and so forth. And so this is going to be, I think, an education process. We're going to have to, I think the statistic that Jim talked about earlier, where the number of prescriptions that come through telemedicine are largely things that are penicillin related, whereas not so much with what you guys are doing. So I think there's cost savings that we could see using the primary care or the local doctor over the vendor, but we have to figure out what that is, figure out how to communicate that. But there is a disconnect, and I think the only way we're going to work through it is to work with you to help us understand how to articulate that, have you demonstrate that value to us, and then we can decide, whether it does need to be cheaper, or we can convince the buyers of insurance that there is added value there that's worth that. The other thing I do want to say is, maybe two more things I want to say. One is I would love to be able to take this opportunity to leapfrog into the next version of medicine, and that's using technology in a very different way, and artificial intelligence. And you think about, imagine an application where you could have all of the screening done by artificial intelligence, and you get presented with a case that has all of the information that's already been intaken and synthesized for you. There are those kind of technologies that are available that could in fact improve the amount of time that you have to take on the call. And the other thing I also want to say is this could also be an opportunity for us to work differently together in terms of overall reimbursement, where one of the things that I know that many of you are suffering from is lower volume. And we could have structured reimbursement structures in place where you assume a certain amount of risk but get a certain set payment every single month. And when you have that type of a structure, there's a lot more flexibility to manage care in the way that you think is most appropriate. So I think I would say that the bottom line on this is there's a lot of work to be done, because we have a bridge to build between the two sets of opinions. And the only way to build that bridge is to really understand what the components are, and be able to articulate those and demonstrate those. So it's going to take some time for us to get there. Jim, is there anything you want to add to that?
Yeah, no, I think you stated it perfectly, Pam. I mean, it's the value that we have to show to the groups that are buying the products, and how we use. There's definitely going to be telehealth moving forward, and there are ways to work together to figure out how to best do this, how to couple it with the technologies, and do other things with it that I think really and truly can show that value proposition. And make it a win-win, because it's not only a win for for the docs and for us, but for the members really too as well. So as I think the main point that we really would want to get across is that we want to work in a collaborative way to be able to work on that kind of value proposition moving forward for the entire healthcare delivery system.
And I think one more thing I would add to that is I think data is going to be our friend here. We can look at, one of the theories is that the telehealth visit is many times followed up with the regular visit. And so to the extent that we can demonstrate that those kinds of things, those kind of data-driven things will help us create the right value proposition and story.
I also think this is where ArMA can play a good role in providing that information. So I think a couple of members have already put it either on the chat or the Q&A. From a patient perspective, right, they see the product, which is the phone call or the video chat. Like anything, you don't want to know how the sausage is made. You just want the sausage. And there's a lot that goes behind creating that video discussion, right? The making sure they're scheduled correctly, that your staff's calling them to make sure it's good to go, that you have access to the information, the work you do after the phone call or after the visit, the documentation, the ordering. There's significant work that goes around it that no one sees behind the scenes because that's what we do. And the question is, how do we put weight behind that when it comes to reimbursement, to time? And these are things that we can provide insurance organizations kind of what we're doing because our time is valuable. And there is there is some sort of connection to what the work we put in. It's just an evaluation of the new version of the work we're doing. We talked before, I look at my institution as a perfect example. My CMIO talked about doing telemedicine for 5 years, and then all of a sudden we had a pandemic, and literally in 5 days we had telemedicine, and now we've done over 15,000 visits in about a 4 to 6 week period. So I think we need to provide the information, and this is where I would like to see us as an organization with our strong relationship with Access, with Blue Cross, provide this information to come up collaboratively on what is the ideal situation, because let's face it, it's here to stay. It's not going away. Patients really like it when they don't have to leave their house to do a doctor's visit or leave their employment. It's a lot easier for them, but we need to have a balance because there is a cost involved. It's our job to really kind of help explain what that cost is, because it's not all completely physically tangible, which is the tricky part.
Yeah, I thank you so much for that perspective, Dr. Goldberg, and we would love to work with ArMA and figure out how to best approach this.
Great, thank you, everyone. There was a question that was submitted earlier to Dr. Selleck asking if Access, will the Access change in telemedicine coverage and current reimbursement levels be permanent? Did you want to expand a little more on that, Dr. Selleck?
Yeah, I would be happy to. So many of the changes that I had described actually already went into place on 10/1. We're not planning on, rolling back any of that expansion. As I mentioned, we've added over 160 codes to the interactive audio video during the emergency. I anticipate that the majority of those changes will remain in effect. It's really just an operational change of adding those that modifier specifically to those codes. I think where we're going to really get into the weeds a little bit with the data is going to be around the telephonic service delivery, simply because we added and greatly expanded the telephonic code list out of necessity during the emergency to allow both our members as well as the providers to get up to speed on telemedicine. And so many of the providers already have, as Blue Cross Blue Shield had kind of articulated in one of their surveys. I think where, especially for our population and Medicaid, where I'm continuing to evaluate, where I have concerns is related to the technology on the patient side, meaning if they don't have access to broadband coverage. So many of our members may live on the reservation or live in rural Arizona where they have limited coverage, and telephonic is the best we can do. So specifically to our population, looking at healthcare disparities and making sure that we can continue to meet the need. And if that is through telephonic, from my standpoint, accessing care, especially for our population, is going to be important, especially continuing now as we continue to monitor the COVID-19 emergency. The other thing I wanted to mention is that on our fee-for-service side, which is the minority of the population, as far as we have about 120,000 American Indians that are served through our fee-for-service program, and we don't have on our access fee schedule, we do not differentiate, even prior to the emergency, we do not differentiate the rates paid for in-person versus telemedicine. So I did want to make that note, and I saw multiple comments come through, the box. And so I understand both, having provided telemedicine beforehand, before my job here at Access, I understand, the unique challenges and the overhead, as well as the, the amount of time it takes to still provide good care. So we have not differentiated the reimbursement rate on our fee-for-service side, but I know our health plans have negotiated through their contract rates with all of you. And so similarly, I would just say having those conversations around the value proposition with our health plans related to the reimbursement rates. But as far as right now, our frequently asked questions still stands as far as our policy decision during this time. We have not changed that directive to our health plans, but they're still required at this time to pay the same for in-person as they are via telehealth.
Fantastic, thank you. I'm gonna summarize one of the questions asked live. Can the panelists speak to how cost share is assigned to members in fully insured plans? I know there was a question about that particular issue, so just provide a little guidance on that would be helpful.
Yeah, so this is when I talk about complexity in the healthcare system, this is one of those issues, and it puts a huge burden on the provider community. We pay telehealth visits at 100% for our fully insured business, and fully insured means that an employer pays a set amount every month in premium, and we assume the risk for claims. We set the benefits, they follow our medical policy, we have flexibility in what we can do with benefits in that structure. The other type of customer, which is about half of our customers, is self-insured, and they just pay us a fee to administer the benefits. So it's just it's a small administration fee. We don't take any risk for claims. That we process the claims, and then we send them a bill, and we say, you pay us $100,000 because we paid $100,000 with the claims they pay us. And so they're paying for the claims, and they dictate what benefits that they want their employees to have. Many of the self-funded clients are not subject to ERISA. They're not subject to a lot of the federal regulations. And so when the requirement kind of came out that telehealth should be paid at 100%, many of them said, I'm going to pass on that. I'm going to keep it at whatever, 80%. And so we have this divide. We've got half of our customers that we pay telehealth at 100%, and half that, and another percentage that have opted not to do that. Now the challenge for you is, how do you know? The only way you know is if you call. And that is a problem. But that is the reality of our world. We have to figure out how to work out some of this complexity. And I apologize, that is very frustrating, I know.
Great, thank you. I think they've got another question here for, I think this is a good question for all the guest panelists tonight. Do you foresee that some type of telemedicine will be covered by payers indefinitely? And then another comment here: for many physicians and members, it seems to be a win-win.
Oh, please, go ahead.
No, go ahead, Dr. Selleck. Please go ahead.
Yeah, yes, we at Arizona Medicaid, we see the advantage of covering telemedicine. And so, as I said, we covered it prior to the emergency, and are planning on covering even post-emergency. So yes, we do see the value in telemedicine, and we'll continue to cover it moving forward.
Yeah, very similar answer for Blue Cross Blue Shield of Arizona. Yes, we covered it before. Yes, we're covering it now, and I think we're very excited about the potential for how it could look in the future, and absolutely, it has a place, and it's here to stay.
Great. Thank you both. I think with that, we're going to go ahead and wrap up here. Let me just share the last few slides on my screen here for you. Great. And just a reminder that tonight's webinar was brought to you in parts by CompuGroup Medical, CGM, ELVI, Telemedicine from CompuGroup Medical. Makes better care possible with secure provider-to-patient video conferencing that allows you to provide HIPAA-compliant care from anywhere, share images, vitals, and findings, initiate treatments and therapies rapidly, offer continuous care to immobile patients, and reduce the workload of your medical staff, all without the risk of spreading the coronavirus. For more information, you can visit cgmtelehealth.com. Quick reminder here, as far as a recap, tonight's town hall was recorded, will be published to ArMA's YouTube channel in the following days. If you have further questions or concerns that you'd like addressed, please do email us at communications@azmed.org. And just a quick reminder as well that resources are available to you on ArMA's website regarding telemedicine, as well as COVID-19 resources, some FAQ, and COVID-19 finance resources. I'd like to thank all of our guest panelists for taking time out of their evening to join us tonight. And thank you all for participating, and we hope you have a great evening. Thank you.